Thank you for listening to the FND Society podcast. I'm your host, Erica Cotton, coming to you from Chicago. I have an excellent team, including Michael Romeo, our sound and production engineer, coming to us from Australia, and our content curators, Ingrid Hurritsauer from the UK and Chrisma Pretorius from South Africa. We also thank Megan and Robert for all their administrative support. This week, our guest is Dr. Jeff Waugh. Dr. Waugh is an associate professor of pediatrics and neurosciences at the University of Texas Southwestern in Dallas. He founded and directs the Pediatric Movement Disorders Program and founded and co-directs the Pediatric Functional Neurologic Disorders Clinic. His research centers on the neuropsychiatric disorders of the striatum, a brain area that sorts and regulates input from every part of the human cortex. His lab studies the interacting and competing functions of the two subcomponents of the striatum, the striosome and matrix, and how imbalances between these compartments contributes to human diseases. His research articles, case series, reviews, chapters, and editorials have been cited by peers more than 1,500 times. In this episode, Dr. Waugh and I discuss the elements specific to pediatric FND, including the role of the family and treatment models, a survey that he completed of pediatric providers regarding FND documentation, communication, and experiences, the role of the medical system in supporting good communication and provider-patient experience, and lastly, FND in the gender spectrum. It was a great discussion about brilliant work and a very enjoyable conversation. Thanks so much, Dr. Waugh, for joining me today. It's a pleasure to have you here. So in order to get started, why don't you introduce our listeners to the world of pediatric FND briefly? We're kind of kicking off a bit of a pediatric focus here. And if you could summarize a bit about pediatric FND diagnosis, outpatient assessments, typical pediatric treatments, especially as it relates to functional movements, I think our listeners would really appreciate that.
Great. Well, thank you so much for having me. I'm excited that the world of neurology and neuroscience is getting more and more interested in FND. And I think that can only help our patients. So it's a great time to be in the field of FND. Whenever I hear someone say that pediatric FND is a rare disorder, I have to wonder which hospital they're working in, because every hospital I've ever worked in, FND has been one of our most common diagnoses. We see it every week on clinical service. Almost every day in a general neurology clinic, you're seeing these patients. So this is a large enough population that if it were a kind of epilepsy, if it were a kind of muscular dystrophy, we would have specialty clinics for that. So this is the reason why we started a pediatric FND multidisciplinary clinic 8 years ago at UT Southwestern. I've got a fantastic partner who's a neuropsychologist. We started it together, and we've seen every patient together now for 8.5 years. So I think that that's something that's been a core of our success, is that we've really had from the beginning this mindset of we need to meet the patient where they are and understand their neuropsychological background as part of our diagnoses. In this clinic, we have had days where every patient referred to us turned out to not have FND. So I think that's an important thought too, that people who are not used to assessing FND do get it wrong sometimes. And we as FND providers need to be ready to say no as well as to say yes when a patient is referred to us. The key things, I think, to making the diagnosis of pediatric FND are a careful examination. That it is almost always the case that the physical exam of a person who has a functional movement disorder is quantifiably different than a person who has the organic equivalent of that movement disorder. Functional tics look and sound and feel different than Tourette syndrome. Functional dystonias look and sound and feel different than organic dystonias. And that's true for functional seizures, functional cognitive disorders as well. So a good FND diagnosis should always start with careful examination and a deep history.
Wonderful. In terms of treatments, in the adult world, which my listeners should know I'm an adult provider at this point, we do PT, OT, speech, psychology, psychiatry as indicated after a consistent neurologic diagnosis, right? Once the diagnosis is confirmed, then we move into this round of treatment, or this realm of treatments, especially multidisciplinary for FND and usually a little more behavioral health focused for functional seizures. Is that mirrored in the pediatric population, or are there distinct differences that our listeners should be aware of?
The availability is going to be different in adult providers and pediatric, of course. So we have a hard time finding resources for people to do inpatient treatment, for example. But when we have those at our disposal, we use the same things that our adult colleagues would use. So all of the modalities that you listed are important ones for us. The big advantage I think we have in pediatrics is the allyship with parents. That if we're able to win the opinion of the parent, we've got the best fighter for this child's recovery. And I think that may be a part of the reason why a pediatric FND tends to recover better than adult FND.
Great. That's wonderful to hear. It's reminding me of our multicultural podcast where across different regions and different countries, it was that everyone preferred the same model, but access and availability at certain parts was different or limited based on how insurances were set up, providers availability, et cetera. So it sounds like it's actually very similar across adults and peds, even within the U.S. here. You mentioned, I can't help myself. You mentioned one component when you were discussing the diagnosis of functional cognitive symptoms. And as a neuropsychologist in adult land, I'm very interested in functional cognitive. And I've often wondered about the presentation of functional cognitive symptoms in pediatric patients. Some of my adult patients go, I don't, or my pediatric colleagues go, I don't think they have functional cognitive symptoms, or I haven't heard that as a primary. But you mentioned functional cognitive, so I'm going to ask: do you believe functional cognitive symptoms exist in pediatric populations? How often do you see it? Are there differences?
Absolutely. So we see it probably once every 2 or 3 clinic days. Someone will have a functional cognitive complaint. Every once in a while, that's the primary functional symptom, but very often that's just an add-on symptom. So the things that help us to distinguish a functional cognitive symptom from other types of cognitive symptoms are the same as the physical exam. So the nature of the complaint itself is key to making the diagnosis. So a person who has functional memory loss will very commonly, a child who has this will very commonly say, I can't remember anything. I can't do homework because I can't remember. And here are the 14 examples of how my memory was off. On Thursday at 2 p.m., I couldn't remember the name of the third actor in the such and such a movie. So there's just a big disconnect there between the ways that manifests in the person's life and true, I shouldn't say true, I'm sorry, an organically based cognitive complaint. Another thing we do to confirm that, though, is effort testing. So my neuropsychological colleague will ask patients to perform tests that are really easy for a person of normal intelligence and developmental level. And if they struggle more than a person of their intellect should, that's one of the ways that the effort-based testing can tell us that this is perhaps a functional cognitive complaint.
I see. Okay. Oh yeah, FCD and performance validity measures could be its own podcast, and some of my colleagues would very much encourage. We might bring you back for that panel in the future.
And I've been a part of lively discussions about that. And this is another area where I think perhaps there's a difference of opinion between adult colleagues and pediatric providers, that on the pediatric side, we have generally, I can't speak for the entire group of us, but in general, we have found these to be measures that reflect our clinical reality. And so there's a lot of just face validity to what we're measuring. But I respect the folks who have made arguments on the other side of that about being cautious about validity testing in adult populations.
Yeah, we are we'll circle back and probably have you as a future guest in panel discussions, because that's an area ripe, especially for functional cognitive symptoms. In terms of functional cognitive treatments, I guess we can have a whole different discussion about available functional cognitive treatments in pediatric populations, and if the diagnostic criteria the same ball at all criteria that Harriet did would apply to pediatric patients. But I'm thrilled to hear this recognition and awareness. I think it's probably similar in pediatrics, right? There's like 80% of people with FND have cognitive complaints, but for a subset, it is the primary. It is the presenting thing that is debilitating. So I'm really glad to hear that this is being recognized, especially within your clinic, and seems like an area ripe for continued, similar to FCD in general, within, I think FND is
And you brought up FND, FCD specific treatment. We generally haven't found that in pediatric FND, we have to have an add-on FCD treatment. It's rather been the case that if we do general FND treatment, and if they need it, physical rehab, et cetera, that also takes care of the FCD. We have not found that someone needed specific FCD treatment.
Oh, that's wonderful. And that might be a difference between pediatric and adults with FCD as well. We've kind of had this somewhat, not opposite. I think in general, FND treatment helps FCD, but some FCD specific complaints, especially if those are more primary or dense, then do benefit from in targeting those symptoms explicitly in ways that, that PT don't
Right.
target, right? Or speech might not necessarily target. Great. Well, I'm just so pleased to hear that in such a comprehensive consideration. What a great span of FND consideration in your clinic and within your practice. I want to be mindful of our time and get into a few major areas where I think you and your team have contributed substantially to our understanding of FND and important sort of central issues that are timely in regards to FND right now, which first one being diagnostic codes, stigma around FND, stigma around coding for FND. And granted, this is in the pediatric population, but I feel like a lot of your findings would equally apply in an adult setting, even though I think the parallel studies haven't been executed. But if you could walk our listeners through the research that you and your team completed that was mixed method, looking at both retrospective chart review and a survey of pediatric providers, and then looking at that data comparison to pediatric diagnostic coding of FND and what some of those main findings were. And it was just, I think, very impactful work. If listener, we'll include a link in the show notes for each of those articles.
Thank you. That was a fun paper to do, so I appreciate you bringing it up. So, I'm going to give an asterisk from the beginning that anybody whose mind has already glazed over at at coding and billing documentation stuff, don't worry. That's not really what this paper is about. This paper is about communication because we found in our pediatric FND clinic that referral notes would very frequently hint to us that the physician knew that the child had FND, but they would never tell the family that. So, for example, we'd see in the physical exam that the patient had astasia abasia, but then we'd ask the patient, look, the note says here astasia abasia, and we're telling you this means FND or conversion disorder or psychogenic, et cetera. And the family will never have heard those terms before. So we wanted to try to get an idea of how often physicians truly communicate the diagnosis when they know it. And of course, an IRB is never going to let us hide secret cameras in exam rooms. So we're never going to get a true accounting of people's communication of the FND diagnosis. But we thought, look, if a person can't even talk about the diagnosis, can they communicate it electronically through the medical record? Would we find that same deficiency of communication in coding that we saw in our own referral notes? So what we did was twofold. We looked at our own practice of all inpatient consults for 3 years, and then a fantastic medical student, Rachel Kim, now an ER physician, she went through each note and searched for words like functional, astasia, abasia, functional seizures, et cetera, and identified notes that were high probability for the physician knowing that this was an FND diagnosis. I went back and looked at each of those and confirmed, yes, this physician is saying that this is FND. And then we just looked at the diagnostic codes that they assigned at the end of that consultation and asked, did they code for it? Did they code for the specific variants of FND, or did they use broader codes? And we found that even when physicians know that it's FND, when they've put their money where their mouth is, written FND in their note, they only code for it 22% of the time. So any study that's trying to look at the cost of FND, the prevalence of FND, the outcomes of FND that's based on ICD-10 codes is going to miss up to 80% of the impact. So, for example, Chris Stevens' paper from 3 years ago that found that the costs of FND care in the United States are billions of dollars per year. It's likely that those costs are inflated by 4 to 5 fold due to this undercoding problem.
Those were two components of those findings really struck me from this publication. The one being, as you said, I previously did a cost utilization in neuropsych, so I understand the glazing over of certain years, although I found it very enjoyable and very, very important. We were trying to answer another important clinical question. But two findings related to what you just highlighted is, in a world, especially in the US, where so much reimbursement and utilization or allocation of resources is ICD-10 coding specific, what a gap that currently is, right?
Mhm.
That does not exist, I think, with many other conditions. So why FND?
Mhm.
Then the other metric along that discrepancy was the rate of providers' confidence in diagnosing FND, which was something like upwards of 80 to 90%, and their belief and confidence and their belief that they were diagnosing it, right? But then contrast that with the 20 or so percent that actually used
Yeah.
a corresponding ICD-10 code. That, for our listeners who don't know ICD-10, I'm sure most of them will, but it's essentially an international coding system on an agreement which signifies we're talking about this diagnosis, and this code signifies this diagnosis. And both of those discrepancies being marked, including the provider's own belief about how much they do diagnose it versus
Right.
the actuality, which is interesting. What do you think accounts for that level of, it's not even
Well,
cognitive dissonance, I guess it's just a agnosia on the provider's part of that discrepancy?
I can answer that in two ways: the anecdotal and what the data from our paper shows. So anecdotally, I have heard for my entire career, oh, if you code it as FND, you'll never get paid for it, or you can't use those codes; those are psychiatry codes, and we have to use neurology codes. So I have heard that from from the attending physicians who trained me, from my colleagues, from people at conferences after my own FND lectures, etc. So we did a second look at all of the consults that were performed in our hospital for 3 years. But this time, not looking just at our own neurology visits, but everybody in the hospital who was not a psychiatrist, and just asked, if someone uses the FND specific codes, do they get paid? And the answer is that they always got paid. I mean, sure, there were times when physicians didn't finish their note on time, or like they didn't send it to the right insurer. Like, yes, there are a few times it didn't get paid. When the physicians did the process correctly, it was paid every single time. There's no such thing as a psychiatry specific code, a neurology specific code. Every diagnostic code in the book is available for every care provider to use. So it's not at all the case that someone is restricted to one discipline for their diagnostic codes. Even if that were the case, practically speaking, you're getting paid. If you write your note correctly, you're going to get paid for these.
Great. That's I think a wonderful um, cognitive distortion to correct for our providers, or an incorrect assumption in encouraging that diagnosis. One other component that your work highlighted was another possible reason for not diagnosing and not communicating the diagnosis. And I think it's very bold's not the right word, brave, but inspiring that you considered to discuss these harder components. And this component being, it didn't always go well in when they made that diagnosis. And I applaud you and your team for including this, because I think providers have neglected to discuss it openly. And I think patients are very much impacted. And I think we hear it all the time from patients. And there's this big gap in how providers and patients are discussing this fairly common phenomenon
Yeah.
of providers, especially in your cohort, a pediatric neurologist making the diagnosis and having a communication breakdown, a breakdown in receiving the diagnosis, appreciating the diagnosis, or even agreeing with the diagnosis, that can result in negative experiences for the provider, but especially, as has been well documented in the literature, patients in terms of stigma, et cetera. And I want I would love for you to share your views and opinions about this finding, why you looked at this finding, and what your interpretation of your findings were as it relates to this common communication breakdown. With a full applause from me and all my team here for even engaging in this conversation.
I appreciate that, Erica. Thank you for highlighting that part. I really think that that's an important part of how we as a field can do better and really need to do better, is in the area of learning how to communicate well. Uh, there are many conversations that we are explicitly taught how to do in medical school. Your family member is going to die conversation. This is a terrible diagnosis. It will end in your demise conversation. We practice those explicitly. Most of us were never taught explicitly how to have an FND conversation. And it should therefore not surprise us that we don't do it well. And thinking back about the conversations that I saw modeled when I was a medical student and resident, the attending physicians that I saw as confident, compassionate people who would bend over backwards to care for patients, when they entered an FND room, would become a less confident, oftentimes less compassionate version of themselves. And that's not a criticism I'm leveling. That's rather an observation that this is hard, and that it's something that if we are not training people to do well, of course people are not going to do it well. And so we as a group dedicated to improving care, one of the things I think we can do better is just teaching people how to have the conversation better. And physicians committing to deciding to do better. That this is an area where if we were getting something systematically wrong in our heart care, in our GI care, if we missed something on an exam and wanted to go back and practice it, most of us would feel the pressure to get better at those things. And that's just not a pressure that we collectively have applied to doing better at FND. So that's the backdrop for why these conversations perhaps have not gone well. But when it doesn't go well, what do we do about it? And how do we approach the next patient who may have a similar presentation? One of the things that was striking in our survey study, where we contacted pediatric neurologists from around the country and had them take a survey about whether they would code or not, and looked at scenarios and asked, would you code in this circumstance, in that circumstance? We had some free answer responses that we thought were just kind of a spillover, in case your answer didn't fit into these categories. And it was very eye-opening how much people vented in that free response. We didn't expect that to be a place where we would get some important information, and boy, did we. People told us terrible things that had happened to them as a result of making an FND diagnosis, losing jobs, having to move cities, being told that they couldn't practice in a certain environment anymore because the conversation went so badly. So I understand why someone who's been through that would be wary of taking care of the next FND patient. And in fact, over 60% of our respondents described that sort of negative impact. So if those of us who are trying to educate the next generation and help our colleagues do better, if we're not acknowledging the trauma that our colleagues have been through and helping them to get past that, then we're not going to be able to help them to do better for their FND patients, because our physician colleagues have often been bruised by prior encounters. And we have to proactively help them to get past that to help the next patient.
I'm so appreciative of you highlighting this complex intersection of diagnosis, diagnostic knowledge, provider communication, patient reception of these components. And I think it's erroneous to, and I recognize it, full kind of caveat to our listeners here. We are touching on potentially deeply triggering and or conflicted areas for debate about how to manage this and what's the cause of this. And at a risk of seeming perhaps too inclusive, but I think it's probably oversimplification to say there's only stigma. It's only the doctors or it's only the patients, right? I think that's just a fundamental oversimplification. And I think if we looked at all of the patients that you, or the patients and provider interactions that you picked up on in your survey highlighted, we could probably find components of each, right? Where it was total provider failure. They have incorrect assumptions, outdated beliefs, and they communicated it poorly and without confidence. And that led to sort of righteous anger on the part of the patient in receiving that diagnosis, and an appropriate reaction of consequences for that provider. To the other extreme of very well-educated, very good provider who made an accurate diagnosis and provided it in a compassionate, thoughtful way, and patient, for a variety of reasons, was not able to hear that. And what is all contributing to those in terms of societal beliefs, expectations, personal histories from both providers and patients. And then I think you also really highlighted an important element. There's a marked sentence in this paper that I really appreciated, which was, a system essentially that creates poor communication experiences as a failure of a system, right? And that in FND uniquely, there's a lack of systems to support good communication, where there's documented high rates of poor communication or difficult communication versus other conditions that are notoriously hard. Like you said, if you have to have a conversation, palliative care, how much support goes into palliative care conversations, palliative care discussions for providers and family versus the level of resources, even from a psychiatric perspective, right? Patients with high psychiatric comorbidity, where we know there's going to be interactive complexity as a provider, not because the patients are at fault, but because they have illnesses. There's high levels of systemic support, addictions, personality disorders, et cetera, where the level of systemic support, provider support, patient support outlets to ensure the most effective communication occurs, and there's safeguards for both sides of that equation. We're really lacking that in FND, despite the complexity and clear documentation. And I appreciate this article for quantifying that. I think it's been an anecdotal experience of many patients and providers. And as a provider, I think I've experienced the whole spectrum. I think a few patient interactions have captured it very well, where some patients come in and some sit down and say, I wasn't told anything. And I see similar notes where the provider kind of documented it and they say maybe they described it, but I'm like, did they really communicate that? I don't know if they did. I'm not 100% confident that they really actually did communicate it to the patient. And then we sit down and talk about it, and then they have buy-in, et cetera, versus other people who come in and they're skeptical, and they're a little guarded with me. And I think they've experienced systemic trauma from multiple providers. And some people have the insight to even say, look, you're believing me. I'm not used to being believed. I've had so many providers tell me that I'm, faking it or whatever. And I just, forgive me if I don't trust providers, but I hear that you're trying to help me, right? And
so I think you raised a really important issue, which is just pragmatically, how do we make this better for physicians, for care providers, and for patients? And in my opinion, proactively unburdening is a big part of that. That most people who have been through the system, seen a lot of ER physicians, seen some previous neurologists even, most of those physicians have heard the phrases you used. It's all in your head. You're faking it. You need to just, get out of this funk and get back to life. Some version of those most people have heard. And so we will usually start the visit by saying, many people who come to this clinic have heard this message and this message and this message. And I just want you to know that that's not how we do things here. And that really starts off not only with just a better interpersonal interaction, but honestly a faster, a more productive interaction. We get through more territory because we're not fighting about every inch of ground. So I find that to just be a pragmatic way to get to the meat of the conversation faster, Another thing that I think is really important for those who are thinking about expanding their FND care or maybe setting up an FND specific clinic is this issue of time. That patients who have FND often take more time than someone else who has a similar type of symptom. And if I didn't have a supportive, hospital administration that let me be flexible, I would have a much harder time. But I have been able to have patients in rooms for hours at a time because the hospital allows me to basically expand into a block of rooms instead of just having one or two. So our longest single day visit was 7.5 hours for one patient. And I wasn't in the room with that patient for 7.5 hours, but we would come in and out and we would find a new problem. We'd have to come back in and come back in, et cetera. So that's something that I can capture the complexity of that extra time using diagnostic codes that allow me to use all my time essentially. And if I wasn't doing that, then I would have at the end of the day a far lower RVU count than if I would, if I was just billing by sort of the consult itself. So knowing how to use time-based diagnosis codes and CPT codes is actually a really important part in being successful in an FND practice, that you've got to account for all your time because these patients are going to take a lot of time.
Yeah, I think that's an excellent point. And I'm hearing a follow-up paper or a follow-up sort of how to run an FND clinic where these complexities along the billing component and these systemic supports are in place, because I think a fair number of my colleagues say, I don't have the time. I can't bill for those. They don't know how. They don't know that they can bill for longer encounters. And then they have to have as you identified, a system, their departmental admin, their departmental sort of people who look at their RVU targets say, well, why did you spend so much time? Or we're protecting your time, or we're giving you extra rooms, and that those expectations for this population are different than 15-minute return slots or a 30-minute evaluation slot that's so standard across most medical settings. And that requires a lot of systemic support and a lot of systemic conversations. I think the other piece that's come up or has been, I think, divergent across a lot of practice settings is also not just on the structure of the visit and time given to the patient, and ability to sit down and have those conversations that are destigmatizing and really getting into all those components and really develop a comprehensive patient approach, is also on the provider end of having some degree of systemic protection for poor patient encounters, right? Yeah. Where it's not going to result in job loss if a diagnosis was communicated compassionately and effectively and due to a variety of reasons wasn't received well, right? Or if the interaction was poor due to a factor completely unrelated to FND, right? Someone's use of expletives about a provider is not going to be associated with that. That's not an FND problem, right? That's a different set of problems that providers can experience, and having appropriate supports in place for the provider to then be willing, I think that would really lower the barrier. I think there's a barrier with providers to engaging with FND patients due to these fears. Well, it's going to go poorly for me, or I'm going to be the one with my star ratings on Google, going through, getting tanked, and versus feeling like there are supports in place, and that systems are allowing providers to engage with this patient population. And I think it's both evolving how we're communicating with patients and how systems are developing to support these patients are evolving at the same time. And that's a hard thing to do. It's a lot to ask of, it's a huge amount to ask of patients, right? Hey, come see us. We don't have it all figured out yet, and systems aren't really fully in place, but we're working on it. But also for providers.
Well, I think that is exactly where we were with multiple sclerosis 25 years ago. That's where we were with Guillain-Barré 25 years ago. So we are starting to figure out some of the neuroscience behind FND in the way that our colleagues did a generation ago. That doesn't mean that 25 years ago, physicians weren't providing capable and competent care for MS and Guillain-Barré. So this is an area where we will meet our physicians where we are today, and we'll commit to getting better over time. But That's something that I also try to be proactive in telling our patients about. Here's the latest research and how we know that this is a brain-based disorder. Here's how we have gotten better in the last 5 years, and where we need to go from here. Patients, in my experience, like to hear about that, and getting into some of the science, of course, helps to build trust that you're a physician who knows this disorder and knows the diagnosis well. So that has only ever helped in my interactions with patients. So if folks want to try that, learn a few papers well, be able to talk about those in your elevator pitch sort of way, it goes a long way with patients.
Yeah, it definitely does. And I think it also helps providers' confidence or providers' acceptance who might otherwise not have been educated in FND or not have been told very outdated beliefs to hear, oh, wait, there is a science behind this.
Right.
These patients aren't just quote unquote faking it. So this again, I just applaud your team for broaching these complex and difficult and evolving practice landscape areas and opportunities for improvement of patient care and provider structure and approach. To create further complexity, let's talk about another complex patient population with FND.
I know where you're going.
Yes, exactly. Which is, especially in pediatric populations, the role and overlap of gender diversity in FND and how that adds to patient complexity and in our patient understanding. And just as a preface for our listeners, prior to this, to make sure I didn't put my foot in my mouth, I asked Dr. Waugh here if there were different base rates of transgender proportions, male to female, female to male, non-binary across the pediatric landscape in FND. And I was told that is not clear and that there wasn't, which I think is helpful when we're engaging in our discussions of just the limitations of our current understanding, but also if you're not aware, it's okay. There's some pretty still simplistic or overarching themes, despite not having some of these details be fully mapped
Right.
out. So why don't you share with some of our listeners, especially your case series that highlighted some of the complexities and common challenges of working with transgender individuals who also have FND?
So this was another project that came out of our clinical observations that we found that we were just seeing more kids in the FND clinic who were on the gender spectrum than you would expect based on the expected prevalence in the population. So the we saw a lot more kids than you would expect. So we started to collect them as you do with any sort of clinical case series, and followed them longitudinally and saw that most of them got better. Which is often the case in pediatric FND, that they do get better. But in these individuals who were in the midst of gender transition or who were exploring their gender identity, and the family was not on board yet, we found that once they resolved that difficult phase, that coincided with their FND getting better. That's a far cry from saying that A caused B, but we did see a time association in this small case series. So we've actually followed that up now with a paper that is about to be submitted. So big caveat: this is not reviewed work yet, but this is a survey project of individuals worldwide who care for folks who have both FND and who are on the gender spectrum. So neurologists, neuropsychologists, psychiatrists, gender affirming care clinics, and just asked questions about which started first, the FND or their gender identity. Was there a relationship between treatment for their gender dysphoria and their FND? And the big takeaway was that people who are on the gender spectrum need FND specific care, that getting FND care was related to improvement in their FND symptoms, much more so than getting gender affirming care. So to be careful in how I say this, I want to make clear, if a physician feels that a person needs gender affirming care, then that's worth doing on its own. But their FND specific care shouldn't be held up waiting for their gender care to get figured out. And it also shouldn't hold up their gender care. So just because someone develops FND doesn't mean that their gender affirming care should be interrupted or put on hold. These two spheres are something that overlaps in the person, but the treatment actually can be going in parallel and not interfere with each other.
And I think that's a very important take home, is that FND care will not resolve gender issues, right? Gender affirming care will not resolve FND, and treating both of those components as it makes sense for the patient
Right.
at that time is essential in holistic patient care and patient consideration in the pediatric population.
Right. And this is an area too where both FND and gender minority status are both things that increase the level of stigma that a patient is going to experience. So having both of those features in one person means that this person is almost certainly born a lot of stigma. And in all areas of medicine, we find that stigma makes recovery harder, makes outcomes less good. So this is an especially vulnerable population that frankly just needs a little extra TLC. So these are folks that maybe I'm just a little bit more gentle. Maybe I'm just spending a little bit more time because I know that these people need it.
Yeah, I think that's such an important thing to highlight. One component, I guess, that came to my mind as I was reviewing this case series, which beautifully highlights, I think, that the different types of complexity that can be present, or the different stages that people are at in FND care versus gender affirming care, and how those run in parallel and are synergistic in a lot of ways, was the role of family. And that might be different for pediatrics across FND, but then especially in FND and transgender experience.
Mhm.
And we see that in adults, right? Adults with lack of supportive environment, but it's not as central, right? For, well, I shouldn't speak for my patients in that way. Perhaps it at least in terms of exposure, people with adults with FND who are transgender might not need to still be living with their parents, but a pediatric patient who identifies as transgender does not have a choice about living within a family system that may or may not be supportive. And that's often not an option for a lot of adults with FND. But what's your team's approach to the family dynamics, and what pearls can we as adult providers take about addressing dynamics for individuals who identify on the transgender spectrum with FND?
So families have by and large not had a chance to learn about, expand their minds about, get to know other transgender or gender diverse individuals before their own child comes to them and says, I think I'm trans. So most of the families we meet are learning on the job. They are figuring out themselves how to deal with this. And I mean, I practice in Texas. This is a state that has made caring for transgender individuals punishable by loss of your license. So this is certainly an area that where it is harder to learn about the transgender supporting medicine than it might be in other locations. So families are often coming to us without the chance to have learned from best practices from other families. They're just trying to figure it out on their own. So I think starting with compassion for the families and knowing that, like, gosh, you have had to come so far to even get to the level of support that you're giving now. So how do I help you do the best job you can do to support your child? And that may not be getting to full embracing of the gender identity for every family member, but helping the family to see how conflict, anxiety, panic symptoms are also triggering for the person's FND is a way that we've been able to help the child's FND just by getting the parent to maybe take a different approach to how they handle the transgender status. One thing that I often will share with parents too is that we've had quite a few patients who came to us with FND who are on the gender spectrum, who in the long run decided that the sex assigned at birth did match their gender identity. They were just in this phase of figuring it out, and that is a I don't know what fraction of pediatric transgender children who are on the gender spectrum will end up kind of coming back to the place they started, but it's non-zero. And in our clinics, at least, a lot of folks do end up coming back to a position where they're embracing the gender that they were assigned at birth. So just helping families to know that like the place we are in this moment is not the final spot, is not where this is going to be forever. Here's how we can help you as you move through your understanding of this. These are all things that help their approach to the FND as well.
I really appreciate taking that model of how families are embracing this component of their child interacts with the FND component. And I definitely hear the approach and think it must be greatly appreciated by family as well, that it could continue to be dynamic across that child's development and lifetime. And that's it. I don't know how unique that is. And I certainly know in the adult world for FND, studies and evaluations of rates of transgender, or where people fall in the transgender spectrum, and the stability of that diagnosis are less, are currently not studied in relation to FND. But I would agree with the hypothesis, especially that in children, given the age in which natural exploration starts to happen, there might be more variability of sort of coming full circle, going in various directions, and not a lack of stability around gender identity than perhaps in the adult population. But I definitely know we don't have those studies in the adult population yet as well. But I think those mirror important issues in adults who identify as transgender and also have FND. And I think there are very similar themes around patient family dynamics and connections and the role of that. I've often encountered in adult populations that having an FND diagnosis, although not just for gender affirming care, yes, definitely for gender affirming care, but various medical procedures. Well, they can't have, the double mastectomy they need because they're BRCA positive and, their mom has breast cancer, right? Because they have functional seizures. And it's like, wait, what? Like, we're not going to give this person potentially life-saving preventative care that we would give to every other patient because they have a diagnosis of FND. This doesn't add up. It's an excellent model.
Well, that brings up an example from the world of transgender medicine that is also true in FND. There's something called the transgender broken arm syndrome, which is, a person who is trans goes to the emergency room because they've broken their arm, and the ER physician says, "Oh, it's because you're trans." That's just ludicrous, of course, but things like that happen all the time, that someone hangs on the hook of their transgender identity, whatever medical problem they have. That happens with FND too. Like, oh, this new symptom is creeping up, it's probably your FND. Well, maybe if it fits the exam and if it's not consistent with another diagnosis that better fits. But we see that all the time, that people see a label and stop thinking. And that's one of the areas where I think people get stuck in a diagnosis that no longer fits, or they make a diagnostic mistake because they're not willing to update their priors and see that, like, hey, the person in front of me today is not the same person as I saw 6 months ago.
Right. And having an FND diagnosis is not somehow neuroprotective. That means other neurologic conditions, seizures, strokes, et cetera, are not going to occur.
Right.
I agree that keeping that threshold. I appreciate your comment, and then the way you phrased it of populations, FND being a stigmatized population, but then especially transgender individuals with FND are sort of doubly stigmatized and are at even greater risk for some of these errors of bias that result in mismanagement or care, and taking extra time and extra care with this patient population, I think applies both to pediatrics and adults. But it's very useful models, I think, that your paper highlighted and outlined. Wanting to be respectful of your time, but also just getting our listeners access to all this wonderful knowledge in your head. What would you say are future hopes or directions you would like to see for the field of FND and pediatrics, or FND in general?
So I spend most of my time directing a lab using MRI to understand the way the brain works abnormally in disorders that affect the striatum. and that part of the brain is involved in many movement disorders, but also in psychiatric disorders, behavioral disorders, et cetera. So we've got a lot of work to do in terms of those diseases. But I feel very strongly that FND is based in a series of brain networks that are malfunctioning. That this is a disorder where if we understood better the underlying pathophysiology, the way the networks are abnormal, we could help better. That's been true for every other aspect of neurology. Why wouldn't it be true for FND? So I think that the work of David Perez, the work of there's actually an FNDS imaging work group that is working on these problems now, trying to do better collectively at having common protocols. So this is an area where I think that's the entree into getting a better knowledge of the way that this disease works. Taking that information to population levels and understanding susceptibility, why some people have stress and get FND and other people have the same stress and don't. I think that getting to population level understanding of FND is the next frontier beyond the neuroimaging. So those are areas that I might take the rest of my career, but that's what I hope we can get to.
Yeah, that's wonderful. I imagine Jersey's probably on that neuroimaging SIG. I would hope so.
There's a lot of people I should list. Absolutely. Yeah.
Wonderful. That's great. Yeah, he and Kurt have really pioneered. Although I appreciate Kurt had told me just recently it took almost a decade to get neuroimaging studies kind of approved for this patient population to get funding for this patient population because it's not regarded as something like MS where of course you're going to take do MRIs or fMRIs to understand various neuroanatomy. I mean, it's just keeping pressure on the scientific community that there are neurobiological underpinnings to this condition. And yes, we do need to know that and explore it. It is clinically meaningful, which is just so great to hear. And I do think, most of our listeners would appreciate, although maybe not our trainees, and there's a fair bit of trainees, that Dr. Waugh is relatively rare, I would say, in having a primary research career, 80% research, while still being so fully involved in a multidisciplinary FND clinic as your primary clinical time, right? I think most FND researchers are clinicians first, and then there's a handful that are primary researchers, but we're skewed towards a lot of clinicians at this point. So I think it's great that you're straddling both sides of the aisle.
It's so much fun. I recommend it to anybody.
Yes, exactly. And hopefully it will become an easier career option, right? For trainees and our students as they're coming up to have both a thriving research career, ideally in something like neuroimaging, and FND, and let both of those things coexist. I just really appreciate your insights and your time and your willingness to go from basal ganglia neuroimaging research to a multidisciplinary FND pediatric practice, and taking the time to discuss all of these highly relevant clinical components with our listeners today. So thank you for your work and your time today.
Yeah. Well, if I can leave your folks with one message, it would be that they and everyone that they can influence should fall in love with FND for entirely selfish reasons. That there are very few patients that I can get walking again after they've had a spinal cord injury, or get talking again after they've had a stroke. But that rush of dopamine I get when I'm able to get a patient back to their level of functioning, there's nothing like it. I mean, you never feel as good as when you're able to help a patient. So this is the population that can give you more jolts of dopamine than just about any other.
I love that the basal ganglia neuroscientist is referencing dopamine. I'm just not going to comment on the irony of that, but that's a perfect way to end this.
I could go as deep as you want to go.
Wonderful. Thank you so much for your time.
Thank you, Erica. Take care.